Good morning, all. I will talk on finding tuberculosis in children in severe acute malnutrition. This is a multi-country observational study. So we know diagnosis of TB in children generally is very difficult because their symptoms are not very specific like we see in adults, and the laboratory tests usually come back negative because of the low bacterial loads in those samples, and sputum samples are very difficult to obtain in children. But the diagnosis is even more difficult in children with severe acute malnutrition because a child with SAM comes with weight loss, and weight loss is a symptom of TB, and you may not be able to differentiate between weight loss from TB or from food insecurity, especially in contexts where we have high volumes of children coming to facilities with severe acute malnutrition. And most of the times, those children are very sick, and they come with other comorbidities, which is also very difficult to differentiate from TB. So, like Kathy mentioned, in 2022, WHO came up with these treatment decision algorithms to improve diagnosis of TB in children, and requested for validation from organizations, countries, to ensure that these are adapted to settings in real life. So in MSF, we conducted the TB-LAM study, which started in 2023 up to the end of 2024 in 5 countries. And this is to validate the algorithm. So in this big study, we have some nested studies. The first one is the TDAs in SAM. So we needed to validate children with SAM using this algorithm, and the objective was to assess the diagnostic cascade as well as the accuracy of those TDAs in diagnosing TB in children with SAM. Then, secondly, the second nested study is the TB-LAM in SAM. We know that WHO has validated the determined TB-LAM point of care urine test for diagnosis of children living with HIV, for diagnosis of TB in children living with HIV. And we know that children with severe acute malnutrition also have a form of immunosuppression, and we thought that determined TB-LAM and Fuji-LAM could be helpful in diagnosis of TB in those children with SAM who are HIV negative. So we assess the diagnostic accuracy of the TB-LAM test in those groups of children, the SAM who are HIV negative. So the TB-LAM study conducted in 5 countries. It's a diagnostic prospective study. Children under 10 years were enrolled into the study with signs and symptoms of pulmonary TB. The countries are Niger, Nigeria, South Sudan, Uganda, and Guinea. So for the TDAs in SAM, we conducted it in 3 countries where we have high volume of children coming in nutritional facilities with severe acute malnutrition: Niger, South Sudan, and Nigeria. The population is children with SAM. And then the TB-LAM in SAM was conducted in these 3 countries plus Uganda. And in Uganda, it's a referral hospital as well as rural health centers. And the population was children with SAM and HIV negative. So this is the WHO treatment decision algorithm, and we followed this algorithm in the diagnosis. So when a child is identified as having symptoms of pulmonary TB, they are put into this algorithm, and then because they are all SAM, then we test the WHO molecular test, which is the gene expert, and also the TB-LAM for those living with HIV. And then history of contact was also asked. And then for centers where we have Xray, it was conducted. And then we scored the children using algorithm A, which has signs and symptoms and chest Xray findings. And then the algorithm B have only signs and symptoms. So whenever the score is more than 10, we start them on TB treatment. But when it's less than 10, we review them in a week and rescore them. So the study procedures in the TDAs in SAM, we followed the same algorithm pattern for the WHO, which is clinical exam, algorithm score, gene expert test, Xray, TB-LAM in HIV positive children. We reviewed them in a week And then we also followed them at 2 months to see how they were doing. And then the TB-LAM in SAM was basically children with severe acute, children who are HIV negative. We conducted the determined TB-LAM and also the Fuji-LAM in those kids, but the results were not used in treatment decisions because they were blinded to the clinicians. So now talking about the results of the TDAs in SAM, most of the kids were under 2 years, and then most of them were hospitalized, and around 2% living with HIV, and around 23% started on TB treatment. The steps of the algorithm, in these 3 countries, Nigeria, Niger, and South Sudan, most of the kids had gene expert test done because we had it in the facility, as well as the algorithm score, which is the WHO scoring system. But most of the kids had X-ray done in Niger, but in Nigeria only 22% had X-ray, and then none of the kids had X-ray in South Sudan because we do not have X-ray in South Sudan. So looking at this, we can see that irrespective of the capacity of testing, whether gene expert or X-ray, you can score the kid with the algorithm. This is also a very important finding because we can see that from the main reasons for treatment initiation, out of the 245 kids started on TB treatment, majority, more than 70% of them were diagnosed based on the scoring system, and around 12% were based on history of contact with someone with TB, and around 9% of them based on the gene expert testing, and only 0.4% diagnosed based on positive TB-LAM, and these are kids living with HIV. Talking about the accuracy of the algorithm, we found a sensitivity of around 84% and also a specificity of around 85%. And we used the reference standard classifying TB according to the international consensus case definition for children. Now talking about the results for the TB-LAM in HIV-negative children with severe acute malnutrition. So 990 kids were enrolled in this study, and then most of them were under 2, just like the other one. Then the accuracy of the TB-LAM. So the determined TB-LAM had a sensitivity of around 38% and a specificity of around 64%, while the Fuji-LAM had a sensitivity of only around 12% and a specificity of around 96%, very good specificity. And we use the same reference standard as the one in the TDS in SAM. So in conclusion, in settings where we have high food insecurity, we implemented those algorithms, and we saw that the main reason for starting TB treatment was the clinical and radiological score. Even though, regardless of whether you have access to gene expert or not, or X-ray or not, we saw this was the most important reason. And then the TDS show a high sensitivity and an acceptable specificity, while in the second study, HIV negative children with SAM, we saw that the determined TB-LAM had low specificity, and the results do not support its use, while the Fuji-LAM showed high specificity, and this could have a potential as a rule-in test. Talking about the impact and perspectives of the study, it had a lot of impacts across these countries. We conducted several trainings to ensure, to ease the implementation of the algorithms in several facilities, MSF and MOH. Also, we conducted roundtable discussions at national levels, which impacted the practices and ownership of these algorithms. And also, it led to policy change in most of these countries where the algorithms are integrated into the national guidelines. And in terms of the perspectives, we think that the TDS can be used in large facilities where we have large numbers of children coming in with severe acute malnutrition. These are nutrition facilities and can be adapted to each context. And we think that in the future, probably new urine-based TB-LAM test may have potential in TB diagnosis in HIV-negative children with SAM. I thank all our study participants and research team, as well as partners, for helping us in this study. Thank you all.
Thank you very much. That was very clear.